Thanks, David, and it's a privilege to be here, both as invited by David Feliciano, someone who I have known for a number of years, as David said, and it has been one of the highlights of my academic career to have the opportunity to work with David and Grace over these last 4 years. It's an honor as well to be able to give this lecture. I knew Henry Laws over the last several years and always was an admirer of his incredible passion for surgical education, and so he has made clearly an impact on a number of us in the room. I have nothing to disclose. I think somewhat of context. David has mentioned sort of the size of the Department of Surgery, and it helps to put some of my comments in context. Our faculty and nearly 100 trainees work in 7 hospitals across the greater metropolitan region. I'm fully aware of this reality of resident evaluation, and however wonderful you think your own department may be, this data has been proven not just in surgery but across multiple specialties. About 20 or 25% of the residents in your department will have performance problems identified during training. I wish it weren't so high, but it is. Most problems are identified early, but the delays are significant in addressing the problems. We have poor evaluation strategies, so we don't diagnose well, and of course our remediation is sort of a penicillin for everything. Probably should just read more, seems to be the usual answer. And so most of these residents complete training with the same problems that we identified early in training. Some of you have heard me say when I first saw this data, I went to my researcher and said, well, I'm confident that's not the case at SIU. And he embarked upon a 30-year review that was later published in Surgery. Our incidence was 23%, only slightly better than what is now a national norm. Several years ago, we identified what we believe the problems are. And we think this is probably from most likely to least likely. It's a little different than what researchers may suggest. The problem really is inadequate sampling of performance. We don't have enough ratings, we don't have enough raters, we don't sample enough skills. Less important is inaccuracies due to over-reliance on memory. Best example, end of rotation evaluation, trying to recall incidents over the previous 1 to 3 months. It would be similar, as Deb DeRosa once said, to doing a month of clinic and then trying to dictate your H&Ps based on your best recollection. Lack of meaningful benchmarks, hesitancy to act, systematic rater error. We were convinced that was a tremendous problem years ago, much less than it really might be. This is data we're all very familiar with, presented at American Surgical in Indianapolis just a few years ago. Speaks to the lack of preparedness of residents when they arrive for fellowship training. This caused a lot of us alarm and a great deal of debate in that particular surgical meeting. Just slightly before that, Dick Bell, in his presidential address to Central Surgical, gave a talk on why Johnny cannot operate. And I want to posit today that probably the reason Johnny and Jessica cannot operate is a couple of things. One is inadequate experience in residency training, but I'm not so sure it's all a volume problem. It may be an autonomy problem. And secondly, a real lack of formal assessment of operative skills in our training program, something many of us have resisted for many years. Lord Kelvin said, if you can't measure it, you cannot improve it. And yet we have tried to do so without good measurement for decades. So I want to speak just briefly about some of our measuring of surgical skills and team-based performance, moving evaluation into the OR, how we measure autonomy, maybe some things you as teachers back in your institutions later this week can do to promote autonomy, and then where I see us headed as we move towards proficiency training, something that I hope will happen and be a reality before I leave Indiana University. The Skills Laboratory became a fascination of mine back in the 90s, and myself and Richard Resnick and several others were absolutely convinced it was the future of surgical training and we must become seriously involved. This was really based on what we were seeing in other professions, and as we know, professional musicians train based on the same deliberate practice our skills laboratories are based on. And we always draw the analogy that if you arrive to Juilliard School of Music on the first day, you don't say to your professor, I was wondering when I might be scheduled for the performance arena over at Carnegie. Instead, any good professor would say to you, I'm sorry, you're going to have to spend months, if not years, in one of these dingy little practice rooms, and then maybe you'll get to Carnegie. And yet often residents arrive to our residencies on July 1 wondering how soon before I get to the performance arena, which is the operating room. And so we've based our skills laboratory on these well-known principles of deliberate practice, and I would suggest that we are able to duplicate this every time in a skills laboratory, but seldom in an operating room, particularly for very junior house officers. And so at Indiana University, we talk a lot about practice arena before the performance arena, proving proficient in the practice arena before you've earned the right to go to the performance arena. Now, we've learned a lot. I think there's some naivete when I started out on this venture back in the 90s of what Surgical Skills Laboratory may offer. I think we realize now the profound benefit is in years 1 and 2. I don't want to pull a chief resident out of a Whipple procedure to go to a skills laboratory. They have to be mandatory. Early on, I saw some of the most spectacular facilities, but they sat empty most days of the week. It was because it was voluntary. And program directors complained that the residents didn't seem to drop by, even though the skills lab was open all week long. They have to be mandatory. We started to realize we need multiple learning platforms. That's been a problem at many places I've visited and was the case at Indiana University, where all of it was based on a live animal laboratory alone. I think eventually we will wear faculty out if we believe in skills training. It must involve more additional trainers to relieve faculty of some of this teaching load. We've had a unique approach with the recruitment of Dimitri Stefanidis. This past summer brought with him a sports psychologist. We're starting to see the profound benefit of someone who's taken all we've learned about training professional athletes and directed it toward performance barriers of surgical residents in the skills laboratory. And Nick Anton has become just an outstanding coach in the skills laboratory. And finally, simulation training. We now realize we've waited too late if we wait into residency program. And so our surgical clerkship, we keep adding more and more simulation, and the student evaluation at the end of the clerkship is, could you have more of this simulation and less lecture and less small groups? And so it's a very valuable hands-on experience for our medical students. Would be difficult to do without a full-time nurse educator, but she pays her way just with her impact on this simulation experience for medical students. Our fourth-year students do what we call at Indiana Readiness Elective. It's called different things at universities across the country. It seems only a few years ago that two of my nurse educators at SIU came to me one day and said, you know, we're not doing a very good job of preparing our fourth-year residents for residency training. Have you ever thought about a special elective? That was back in about 2003, and we did it one year, and it sold out, and since then became the most popular elective. And so it's now fairly common across the country, and now an ACS GME committee set of curriculum guidelines for this experience. One of the best experiences of my life, and some of you in the audience were involved in this, was when the American College of Surgeons and the Association of Program Directors asked myself and Helen McRae to co-lead an effort to really develop a comprehensive skills curriculum across the United States. I would say that now it's being used worldwide, and really helped us at least get a handle on skills laboratories so that every program didn't have to reinvent their own curriculum. You're all familiar with the 3 phases, and basically I'll just tell you how we implemented at Indiana University, and this has been a trial and error process over the last 15 years. We have a boot camp for all of our PGY1s, and this is plastics, urology, vascular, general surgery. So it's a group of about 28, and when we built our new skills laboratory, it was designed to accommodate that group of about 28 to 30 learners. It's 12 weeks once they're a bit oriented to the wards. It starts the first week of August, goes weekly for 2-hour sessions, 9 of 11 verification of proficiencies completed by the last session. Obviously heavy faculty involvement, but we changed the expectations several years ago so that it's not taught by a few core dedicated faculty, but if you're a faculty member in our department and your specialty is the specialty in the skills lab today, you're expected to be there, since those sessions are scheduled 1 year in advance, and really no excuses not to be there. Phase 2 is a lot of work in cadavers and models. We have several cadaver sessions, and during that week of cadaver sessions, there may be 3 skills laboratory sessions a day from multiple divisions in our department, plastic surgery, transplant, and others. But again, an experience in the skills laboratory, in the practice arena, before the performance arena. I think you might expect us to use a lot of virtual reality, and we don't use that much. We have a significant amount of it, but I think we've been more critical than some about the educational value. And our question is always, is this the best teaching platform? If so, it's worth the investment. If not, maybe there's a better model. And so we use it for some of these essential tasks and those operations where to date we have not found an acceptable model as an alternative. We've recently purchased this simulator. It's revolutionized, I think, the training in cardiac surgery. We're now starting an I-6 curriculum where every Wednesday morning our I-6 residents will be here. This is a rather costly model. It's about $100,000, but really using a pig heart in this simulator allows residents to do multiple coronary artery bypass grafts and valves. We're now determining how many of those do you need to do before you've earned the right to do one in the operating room. I think team-based training is really illustrated by this picture, and I want you to particularly pay note to the sweat on the brow of the tall guy in the middle. If you think these aren't realistic and don't get residents' attention, you only have to observe one. They are very realistic experiences, and we have found them very valuable and continue to increase the amount of team-based training, working with anesthesia, nursing, and other specialties. Most recently, we did a managing of an intraoperative crisis, one of those 10 scenarios in the ACS APDS curriculum, managed by Peter Hammer at the time, who we call him Commander Hammer. He did this same thing in the Navy and the program at USC before we recruited him to Indiana. This is a scenario where once the third-year resident puts a trocar into the abdomen, it punctures the aorta, massive exsanguination and crisis, and it's really very instructive to watch how that resident manages that intraoperative crisis and the valuable experience of being debriefed by Commander Hammer in the room next door after the scenario. Here are the essential team-based skills as we design new scenarios. These are the things we're trying to weave into each of those various team-based training scenarios. Some happen in the simulation center, some can happen in the post-operative recovery room, and even in the surgical ICU. Simulation at IU is in these three facilities. We have a new 1,600 square foot surgical skills laboratory. We still have our live animal surgery. It's just a much less portion of the curriculum. And then I think very importantly, our simulation center, which is a school-based facility, the other two managed by the department. Our surgical skills laboratory is a very pleasant facility, and I think faculty who had never worked there before found it an engaging place to be without all of the aroma of a cadaver laboratory. And again, it accommodates 30 learners at a time, allowing us to do a lot of CME courses and other evening and weekend courses that help supplement the budget of a skills laboratory. Our live animal laboratory is the setting, for example, for courses like ATOM, where all of our third-year residents undergo this trauma course one-on-one with the surgical faculty, an exceedingly valuable experience as they then go to the level 1 trauma bays. Our simulation center is almost like a hospital with an inpatient area, an outpatient area, an acute care area, and an operating room that is fully equipped and is, again, an ideal place to do team-based training for our surgical residents. Let's talk about evaluation. One of my frustrations, I think, over the last 2 or 3 decades is I've visited facilities and they tell me about their curriculum, and then always are so disappointed when I say, tell me about your evaluation. And I think there's a sense that if we've actually succeeded in getting faculty to show up and the residents at the same time, and we have somewhat of a session, that surely would be enough. And yet we can't invest the kind of dollars we've invested in surgical skills training without being sure that those skills are actually gained. And so we, several years ago in the ACS curriculum, developed this verification of proficiency modules when several of the participants in that effort said to me, we'll never get our faculty to come and devote a half day every 6 months for OSATs and watch residents progress through 20-minute stations. Might work at your place, they said, you better come up with something else. I cannot imagine anything that's more faculty-friendly than verification of proficiencies. And so in all of these areas, they review a video of expert performance, then they have guided practice with the faculty in the skills laboratory, then they continue to practice on their own time with a laboratory that's available 24 hours a day. When they're ready to be videotaped, they're videotaped with in-light cameras, and our video capture system sends those videos to the expert faculty laptop. More importantly, they evaluate them, give feedback, and give them a pass or a fail. Pass means, I'll take them in my OR. Fail means, not quite yet, back to the skills lab for more practice. This is how it sometimes appears on the laptop, and you give them their ratings, and that's valuable information if they fail for our skills coach to help coach them to a level of proficiency before they would be able to operate. And for example, residents in our program would not do a access graft on the transplant service until they've passed the module on vascular anastomosis. Let's move to the operating room, because now once we are certain they are proficient in the skills laboratory, we're ready to move to the operating room. And let me just dismiss this question, because almost every time I've talked about operative skills, someone will ask in the audience, can't we do a better job of predicting great technical aptitude when the residents arrive as applicants? And if we could do that, wouldn't that make our job so much easier and we wouldn't have to worry about remediation? Well, this is the best study to date, just published last year, a wonderfully done meta-analysis, and the simple answer is absolutely not. You're still going to have to teach and measure and verify and remediate, because a review of 52 studies looking at all of these special tests shows no single test and no combination of tests can predict validly this resident will succeed with regard to surgical skills. So several years ago, Reed Williams, a researcher that I've worked with now for 17 years, we realized we were doing miserably in rating operative performance. I was a program director at the time, and at the end of the year, residents would throw on my desk all of the cases they had done in the last 5 years, and my job was just to sign them, assuming if they had actually done those cases, they must be proficient. Made me extremely uncomfortable because I was certain some of them were not. And it put us on about a decade-long venture to do a better job of measuring performance in the operating room based on a single incident. This was our first effort, and as many of these cases, it's modified over the years, but we identified commonly performed procedures and then did vigorous literature searches to find those things that predicted good patient outcomes. That was the basis of our rating forms. And then we piloted the instrument and then went through an exhaustive study at the American Board of Surgery validating this instrument. Probably some of you in the audience participate in those long sessions in Philadelphia, but we learned some valuable lessons in that process. First, we learned that the focus on operative performance has to be where the resident does most of the planning and directs the team. It's hard to evaluate a surgical intern when it's mostly the attending moving the table and the intern holding the knife. So we have to be very careful when we say this is an evaluation of performance. We learned overwhelmingly that we all guide more than we think we do, and it interferes with evaluation. Several of our expert raters in Philadelphia said, this may be a chief resident, but I can't evaluate them because the attending is coaching them every step of the way. And then, of course, I learned in my own program when I proudly boasted that I don't provide guidance because I've been doing this for a long time. They asked if they could videotape my performance and brought it back to our whole education group and showed while I was not directing the resident, I was routinely directing the resident in every step with my discussion with the medical student. So next what the resident will do, and after that you'll find what he will do. So all of us do it. If you think you don't, just ask someone to videotape you in the operating room. You'll be amazed how you do it with lap placement, camera guidance, and other, sometimes obscure methods. This vector has been around for years. Frank Stritter from North Carolina put this forward, and it could not be more relevant as we think about autonomy today. It's appropriate to hover for a first-year intern. They need a hovering attending. But it is stifling to hover as a chief resident. And so what we as faculty need to learn is how to withdraw those cues and step back to allow autonomy with increasing resident experience. We learned some other things about operative performance. In the past, we really struggled with language when a resident was struggling in the operating room. We couldn't be very specific. And as we analyzed over 1,000 of these expert comments, we now are able to be very precise and say a resident struggles in one of these 5 areas. It's either purely technical, maybe it's forward planning, which happens very, very frequently, it's in self-direction, it's in patient safety and judgment, or maybe it's in situation awareness. It occasionally can be a combination, but this helps us, again, going back to the beginning, making a better diagnosis, being able to provide better remediation. Our first pass at this effort was called BEST. It was developed at Indiana University with a group of IT folks. We ultimately saw this as a platform to coach physicians in practice as well as residents in training based on this large number of 10-item operative performance checklist we had developed. I wish I could tell you that the faculty were so wonderfully compliant and never complained about a 10-item checklist after every case in the OR, but as you know, that was not the case. And so we began to think, let's make it easier. The iPhone app improved it, but still our compliance was a struggle, and we felt we were missing something. Along about that time, Dr. Zwischenberger at the University of Kentucky, the Northwestern group, began to talk more and more about autonomy, that maybe it wasn't enough cases, it was enough autonomy for our graduating residents. And so we began to think very carefully about how do we as surgeons promote autonomy. We did a series of focus groups. Our program director ran this study, and we came up with some of these suggestions in talking to experts evaluated by our faculty as allowing great autonomy. We learned some things not to do from those our residents say they never change their level of autonomy from year 1 to year 5. One is to sequence increasingly complex steps of a procedure for graduated autonomy. A called our chief of transplant in one day and said, "How do you do graduated autonomy for your fellows?" And he rattled off the top of his head this system that he'd been using for years. He said when they come in, the first 15 cases, they just first or second assist. Then they open the hilum. Then they strip the liver off the vena cava. Then after about 60 cases, they get to doing the duct, cava, and portal anastomosis. And maybe they'll do the entire case at the beginning of year 2. A very systematic approach of graduated autonomy. And I would ask you to have that level of approach in the cases you do routinely with surgical residents. Of course, we've already commented on minimizing queuing for senior residents. Don't just do something, stand there and let them find their own cues. And then the BID method, which was developed actually by a surgical researcher who asked if she could come into my operating room because she felt like we weren't doing a very good job in making our instruction individualized for resident learners, and so was developed the BID method. If you've not used it, I would encourage you to give it a try. It can really revolutionize your teaching. This happens at the scrub sink where you ask preferably a more senior resident, so from your perspective today, what is the one thing that you believe you could learn from this case today? The one thing you're struggling with as much as anything else. In the operating room then, you do the usual teaching scripts, but when you get to that part of the operation, you really focus specifically on rich feedback to improve performance. At the end of the case, as long as the debriefing is not too harsh, you can do it right there in the operating room, discussing with them, so here's how I thought you handled that particular aspect of the operation. How do you think you've done? And again, I think you'll find, when I tried this the first time with a chief resident, ask me, why did I wait until the 5th year to start doing this? So if you've never tried the BID method, I would encourage you. It will, I think, in some ways prevent you from case takeover. Now here's another method that I think was reinforced in one of our workshops recently by Demetris at our institution. I would guess everyone in this audience has had the experience of being in the operating room with a 1st or 2nd year resident, and you are eloquently describing what you want them to do, and it's just not happening. It's as if they're not hearing a word you say. Well, here's the problem. As an attending, you can focus on the case and judgment and decision making and still have lots of extra attentional resource to deal with everything else happening in the room. But if you're a novice surgeon, every bit of attentional capacity you have is taken up on listening to attendings and psychomotor performance and comprehending instruction and doing the technical aspect. Now on top of all that, your attending wants you to listen to this new set of instructions. Nothing registers. So how do we fix that? Our frustration is usually just take over the case. And instead try this week when you're back in the operating room and it's just not going well. This comes from a group of colorectal surgeons in England. Stop. Everything in the OR stops. Ask the resident, why do you think we had to stop this case? Then from your perspective, explain what the problem is, explain the technique that you think will help get them back on track, make sure they understand what you're saying, and then make sure you think they're able to do that, and if so, don't take over, resume the case. I thought I was doing this, but since I've again reapplied this to my teaching in the OR, as I typically work with a 3rd year resident, it's been amazing how much more comprehensive they're able to listen to your instruction if you actually stop and have their undivided attention and full attentional capacity. Insist on resident preparedness. I think folks think that at Indiana University we're just all kind and gentle, but we have high expectations about residents on elective cases in the operating room. We've really explored longer senior resident rotations because we have heard loud and clear that attendings give more autonomy when they worked with a resident over a period of weeks or months. So in this past year, we're experimenting with 6 apprenticeship rotations, long rotations with very busy surgeons. The initial experience is outstanding. We'll be measuring autonomy to see if it changes from those shorter 1-month experiences. And then, of course, include autonomy in the operative assessment, and we have not done that until recently. I don't think there's a better way to assess autonomy over the Northwestern or Zwisch autonomy scale, and if you're not familiar with this, it's really just 4 levels. Show and tell means I operate, you watch. Active assist means I do most of it. Occasionally I let you participate. Passive assist is what we generally do for mid-level residents. We help occasionally, but they do much of the case. And for chief residents, we would hope it's at supervision only. Our arms are crossed. We're talking to the scrub nurse. The resident is operating. We're watching and in the room. When we began to realize the value of this, I pulled our research team at Indiana, with the research team at Northwestern, who was convinced that the only thing that mattered was autonomy. And we worked with ultimately Massachusetts General as a young man there was finishing his fellowship and then went back to join Keith Lillamo at Mass General. And we said the best is probably combining a quality measurement with an autonomy measurement and a case difficulty measurement. So we went from that 10-item checklist, which was burdensome, to something that could now be completed by faculty, and I've done it enough to know, in 45 seconds or less. Now there was no longer any excuse for not doing this on every single case, every day in the operating room, with every resident who was doing most of the case. So this is now simple. It was launched as a not-for-profit corporation. It's now a procedural learning and safety collaborative. That's the research arm of it. We've completed all software development of the app-based program. It's for iPhone and Android. And we've actually, just a few weeks ago, completed a 14-program review of Simple, sponsored by the American Board of Surgery. One of the requirements is that if you participate in Simple, you must go through faculty training. We must share a common view of what the various ZWISH ratings are if we're going to trust the data that comes out of it. I'll just show you some of the remarkable data that's coming out of this. I won't want to preview what will be presented next month or the month after next at American Surgical. But if you look on the right, if we're looking at just the quality of performance, where we would like to get residents to is a 4 or a 5. 4 means practice ready. They're ready for independent practice. 5 is one of the most remarkable performances we've ever seen. And as you can see, in these first 4,000 unique observations of residents across 14 training programs, it's a little concerning that at chief resident level, only 70% reach that area. We've never had data like this to get a picture on the quality of our residency training. Now what about autonomy? This is a little more concerning, but still we would like to get all chief residents at least to passive assist or supervision only. But to date, and again over 4,000 observations across 14 programs, we're only getting there about 70% of the time. So it's really been interesting to look at this data. And here's some of the factors that we've examined. This was just presented a few weeks ago at the Academic Surgical Congress. We examined in this group 7,000 performances in 14 programs, and we seem to have a handle on at least what some of the major factors are that determine how much autonomy an individual gives. Fortunately, it's the resident's operative performance that's the #1 factor. Attending prior guidance habits. Old dogs don't always learn new tricks so easily. Case complexity, that's different than absolute complexity. So it's how difficult is this lap hernia compared to all of the other lap hernias. It's not how difficult is this Whipple compared to a hernia. The PGY level had minimal impact, and we've now identified a few other factors that we know are at play but difficult to measure. The faculty trust, absolute complexity, less on a Whipple than a hernia, and the current workload of that faculty in the OR. All of you know that if you're in a busy day and you're a case behind, things are not going to go as well for the chief resident and their level of autonomy. Back in the early part of the last decade, when we first started talking about operative performance, this was my dream. Wouldn't it be great if we had the kind of measurement for skills in the operating room that we have for knowledge? So we know that a resident is in the 60th percentile on ABSITE. Wouldn't it be valuable to know where they stand with operative skills? We are now able to do that. This is what it will look like in a report given to each resident every 6 months. You'll see where you are with regard to all other peers in the country at that level of training compared to the median. And hopefully, if you're a red dot below the median, you'll be heading to the skills lab to try to improve your performance. But we've never been able to provide residents with this kind of data, how they compare. I think it'll provide valuable information for program directors as they look at the complement of residents in their programs. Having been involved with this for now about 14 years, Reed Williams and one of our former fellows felt like we should really collect all of the literature together in one place and do a comprehensive practice guidelines for operative performance. We reviewed it in 2 phases, what your program should look like for evaluating individual performance and what your system should look like in your residency training program. We established criteria that we assess the strength of recommendations using EAST and GRADE, and then we asked stakeholders to review our initial findings. We went to the ACS, the ABS, picked out scholars in this area from the US, from Canada, from Great Britain. This was published just in December in the Annals of Surgery. So here are some single rating guidelines that we feel really confident would be a great checklist in your program. It should be for a single performance. It has to be directly observed. One of the interesting findings that if it's not entered in 72 hours, it's no better than a HALO rating. And so our system locks out the faculty member. If you don't get to it in 72 hours, it is not going to be specific enough to be of value. Has to include a report of autonomy, case complexity, rater training is essential, and if you dialogue after an outpatient or operative procedure, obviously that's the most effective form. I wish I could tell you that our faculty do this every single case, but at least with this simple app, they can push a button and dictate feedback as to what they want to see in that performance the next time they and the resident are together. This is for your system of operative performance, a good checklist. All performances should be rated. It's just easier to look at compliance for every single program. If you're doing a subset, it has to be random. We've learned you can't let the resident decide which performance is to be evaluated. You have to have at least 10 raters to sort of get rid of rater idiosyncrasies. We're all doves or hawks. The operative performance is stable enough to do this once every 6 months. You only make decisions by your milestones committee after they reviewed these reports, not on an individual rotation. And to assure chief year competency, multiple ratings with high autonomy are required. The American Board is starting to wrestle with this. It's not enough to know how many cases a resident did. How can we assure in that final year they had adequate autonomy? Well, I think it's pretty clear that this instrument will give us that answer. So the next step, as you can see, as we gain this data and this understanding, is moving toward a true proficiency-based operative performance system in all of our residency trainings. What would it look like? Well, we'd have to determine the number of observations necessary for stable assessment. And actually, we just completed this research work, and I won't reveal that information ahead of publication. But the focus on individual case proficiency for common cases. Now, it may surprise you. We always assume there's this large number of cases that our residents do very frequently. This is recent data. These are the operations performed more than 20 times during residency. This is a likely place to focus. Lap chole, open hernia, partial colectomy, ventral hernia, endocrine surgery, and laparoscopic inguinal hernia. That's it. The others are much less frequent. So, mean practice-ready performance for remaining cases at least that last 6 months of the chief year, and a requirement for a minimum level of autonomy in the final year. That should be a consensus of educators across the country, in the APDS, the ACS, and the American Board of Surgery. But we feel like it's time to take the next step, and as you know, the only experience that we're aware of that has been widely studied is the orthopedic surgery experience in Toronto several years ago. It's not been done in the US, and to redo an entire training program would obviously require consent by the RRC. So I want to make sure, so that I'm not reported to the RRC this afternoon or tomorrow, we are doing a single curriculum pilot. We have not felt that the RRC needed to give approval because we're taking a single rotation and taking that one commonly performed procedure. This will be a laparoscopic cholecystectomy module during 1 month in the PGY2 year. They'll first complete the cognitive component with testing, and this is being developed by Dimitri Stefanidis and his team as the director of the Skills Laboratory. They'll complete what we already have in place is our 3-step Skills Laboratory segment. They first do a lap chole in a live animal, then they move to an explanted liver and gallbladder in the Skills Lab, and finally proficiency testing on the VR lap chole. They go through all of that before we're now ready to move on to the operating room. They will carry a pager for assigned lap chole cases morning and afternoon all across campus until proficiency level is achieved. That's what we're currently examining. It'll be a number of cases at practice-ready passive assist or supervision only, and obviously will require a set number of faculty observers. We'll learn a lot from this first experience, and then we'd like to expand it to a multi-center study across the United States. We believe this is a logical, safe step toward ultimately an entirely proficiency-based program. I remember Roland Full saying to me shortly after I arrived at SIU, sure that this was only 5 or 6 years away, back in '97, before I retire, he says, I hope we get to a proficiency-based residency training instead of it must be July 1, it's time to move on. I'm still hopeful that may happen before I finish my training, my current role. Well, let's look at some outcome measures for this proficiency pilot, and Dimitri and I and others have been hashing this out in our research team meetings. Obviously, the time it takes to achieve the laboratory-based proficiency will have a great measure, but this is the formula. Rate of performance improvement So we're looking at the performance after the intervention minus their baseline performance. Some may come in already a little more capable than others over the training duration. Placed another way, we're looking at the slope of the learning curve. We believe we can make that slope much different in this focused proficiency module than the usual sort of hit or miss residency experiences. And obviously our assessment will be with simple, and we'll also be doing video assessment in the operating room. And then of course the number of operative cases to achieve proficiency compared to simple controls. We're convinced this will be a lot fewer cases with this much focus. In closing, I want to give attention to the most incredible team I've worked with. One of my dreams as a young surgeon when I started to think of surgical education was to someday be able to sit in the middle of a wonderful research group and basically just applaud their efforts and just be responsible for finding their money. And I think we finally arrived there. We really helped our cause tremendously with the recruitment of Dimitri Stefanidis this past summer as our Vice Chair of Education. One PhD just focuses on professional development with, I think, just a wonderfully comprehensive professional development program. Reed Williams is an expert in performance evaluation. Our program director is now in a master's program. I mentioned our sports psychologist and nurse educator. We have a foreign visiting fellow from Japan based on Dimitri's work. 2 of our residents are now entering this summer into the laboratory where they will spend 2 years in surgical education research and get a master's degree. We've added to this team just in the last few days another simulation researcher. Dimitri and I are working to add a human factors specialist that will spend part of their time working with the health system and ergonomics in the operating room and the other half of their time working with us in our laboratory. Now obviously, to accumulate a team like this required funding. That was my job. So we developed a wonderful relationship with Biotech, which is a subsidiary of Cook Company, a very large company in Indiana. They use our skills laboratory for a lot of their training sessions. They realized the value of what they were doing, and a few months ago awarded us a $2 million grant, which really gives us a wonderful head start in a lot of studies and investigation that otherwise we would be unable to do. To give you an idea of the kind of imagination Dimitri has and the research team as they look forward, this is the proposal for this grant funding for the next 24 months, just some of the ideas. And we also happen to have a rich collaboration with the Weldon School of Bioengineering at Purdue, which is literally 1 hour away. We'll be doing simulation-based automated feedback, trying to offload faculty tasks and feedback and evaluation, using things like 3D printing and internal sensors, conductive microparticles for suturing, anastomosis, trocar placement. I have to say, when this one came up in the team meeting, I said, they've gone too far now. Wearable technology to assess non-technical skills in the OR. And not that I wouldn't love to have some real data on how professional our faculty are in the OR and these non-technical skills. And wouldn't you know it, about 3 days after we discussed this in our research meeting, and one of the Purdue investigators who's an expert in wearable technology, I was driving to work and heard the report on NPR. This is going to be the future. So not so far off. You can see the kinds of things they'll be using in that study. And then a video-based platform for coaching surgeons in practice. This will be a SAGES study focusing on the seldom obtained critical view of safety in laparoscopic chole. Another interesting, provocative idea: can art interpretation-based instruction enhance pattern recognition in surgical trainees? We'll tell you in about 18 months. And then using a novel mental skills curriculum, this work, Dimitri came with an AHRQ grant and has worked on extensively. Can we use this to enhance resident resilience and grit and prevent burnout and optimize performance? This has already caught the attention of our School of Medicine, and they've asked Dimitri to incorporate this in a medical student curriculum, and we think this will be a valuable adjunct to resident training. So in conclusion, as we think of measuring and improving performance, we have to separate the practice arena from the performance arena. Those can no longer be the same. Broadly sample trainee performance. Often people ask, well, how many ratings do I need to assure I'm sampling broadly enough? And Reed Williams did this research a few years back. It's 38. So of all of the evaluation you have on a surgical trainee for 1 year, it can be cameo, it can be operative ratings, it can be all of the various things, including end of rotations. You need 38, particularly if you're evaluating professional behavior. Measure performance based on direct observation. We realized years ago hearsay was not adequate. So I'm not really concerned what a nurse said about a resident and told a faculty member who told the program director the day after. I like getting those letters, but I want our evaluation to be based on direct observation. And finally, we have to work as faculty on promoting greater autonomy, and sometimes it's just removing the barriers. And finally, measure, don't assume for proficiency, ultimately heading toward a mastery-based approach to surgical training. David Leach understood this years ago. Whatever we measure, we intend to improve. Thank you very much for the privilege of speaking to the Southeastern Surgical.